Bismillah ar-Rahman ar-Rahim. Today we will be discussing. First, I would like to welcome everyone on board. I would like to welcome the panelists, the organizers, and I would like to welcome the attendees who we will discuss today, inshallah, about the different aspects of management in venous thromboembolism. So we will go through the challenges and the diagnosis of VTEs, either it's from pulmonary embolisms or deep vein thrombosis. We will also go into we will see these challenges, what are the aspects that we will need to do, what are the different diagnostic modalities that we will be using in diagnosing VTE. We will also go through when do you see that this patient may require to have an extension of his anticoagulation. So when is prolonged anticoagulation an issue, and when do we consider it? At last, we will need to touch on how much the aspects of COVID that is associated with a lot of prothrombotic factors and VTEs that is associated with it. So without long dues, I would like to introduce Dr. Saeed Athar for our first speech. He's a consultant in Sheikh Khalifa Medical City, Abu Dhabi. He's having the fellowship of Royal College of Physicians. He has special interest in pulmonary diseases, acute care, and thrombosis. Without any delay, I would like to allow Dr. Athar to start his speech. Thank you very much.
So thank you very much, organizers. Thank you very much, Abdullah, and thank you very much, Emirate Society of Medicine, for inviting me. So thank you very much. From my age and from my introduction, you all know I'm the physician of the time where we were using the chalkboard and the blackboard and the chalk to use the presentation and do the presentation. PowerPoint for me is like this poor chair in front of the others, and this is what the managers and the organizers have done to me. So I'm sorry for my PowerPoint problems.
It's not an issue.
The important thing for this is, let me just see, it's not working. So for everything, we have the learning objective, and first we are going to do the high challenges in the area of VTE diagnosis to correctly interpret the diagnostic information and to apply the relevant evidence and guideline to the real world cases. The important thing is why we think that the VTE is important and why it's a challenge. Because it kills more than, even only in the America, it kills more than 200,000 with the PE. It's more than the Bressier and AIDS. And again, the most important thing is, if you look into it, the untreated PE has a mortality rate of approximately 30%. And nearly 30% of untreated DVT will result in swelling and ulceration of the leg with the chronic problems. But if you diagnose and treat the patient early and properly, the death is less than 1%. And then you avoid the unnecessary treatment with anticoagulation. So the important thing, why we need a good diagnostic approach, and that's the reason why what are the challenges which we can face. You all are a clinician, and you know the diagnostic approaches are, first you take the history and physical examination, and for diagnosis of DVT, PE, and VTE, there are problems, there are many challenges. Then you always think of the probabilities, the scoring, how you think it's a DVT, PE, or no PE, and no DVT. And again, there are many challenges at it. And then if you can't confirm or you can't exclude, then you go for imaging studies. And unfortunately, in case of VTE, there are challenges in it. So from the diagnosis till the confirmation, on every step, you find the challenges as a junior doctor, as a senior doctor, as a consultant, and it's a daily business. Every day you get a patient of a PE or a DVT, and I try to summarize what are there and could we reach to something. We commonly use the word pretest probability, and the problem the prevalence. So whenever you see a DVT, you always think, is it a DVT or is it not? Should I go for the testing or not? And you do some pre-probability testing, which is called the clinical decision rules as well. And at the basis of this, you classify them into either low, intermediate, or high probability, or likely, unlikely to have VTE. And if your probability is low, the prevalence of VTE is low. And if it's intermediate and high, the prevalence of VTE is high. But this is the problem. The problem is that you miss the PE and it's death. You miss a DVT and it's a problem. It's a extension or it's a post-thrombotic phlebitis. So will you just only take the prevalence and the pre-test probability and believe it and leave it? It's a very difficult clinical decision. When we say the VTE, it's a DVT, it's a PE, it's thrombosis at the unusual site, and it's thrombosis at special groups of patients. And this is important in clinical medicine, that whatever knowledge you gain and whatever knowledge you have to ultimately put it into the real world cases and the real world case scenario, that how you are going to, what you are going to do with the patient when you see them either in the ER or in your ward. The deep venous thrombosis is the common one, the quick one, which we most of the time, every one of you may have seen them. And there are two pre-test probability scoring for it. Like say the common one is the Wells score for the leg DVT, and then the Constantine score for the upper extremity DVT. And we all look into the lower limb DVT, but no one of us consider the upper extremity DVT. But those who are working in a hospital medicine, this is the thing which we usually see after PICC line insertions and catheters and other problems. In the Wells, the thing is the same. If the score is more than 3, it's a high probability. And high probability means there is more than 50% of prevalence. Score of 1 to 2, and it's intermediate probability. And if you look to the list of the scores which is there, almost every one of your admitted patient will be score 1 or 2. So it's very rare in a hospital medicine to find a score of less than 0, but you working in a private, you working in an outpatient clinics, RHS, may find a low probability as well. The low probability still have a 10% chance, and the high probability have a 50% chance. So for me, it's confusing. If I see there's a less than 10% chance, but it could be 9%, should I do something or should I not do something? It's a difficult problem for me to face. The problem with this is, in the pre-test probability, the high risk of VTE has diagnosed, confirmed by imaging, in 40% of the time for the PE. So this again a problem. We are using VQ stain, we are using CT angios. Our pre-test probability is high. If I do the 100 tests, only the 40% will be positive for PE. 60% of the time, I'm exposing the patient to the CTs, NGOs, VQs, and other investigation unnecessarily. But the DVT, I'm more sure, 85% of the time with a high probability will be PE. But the 60% of a high probability coming back as a negative is a challenge. And I'm sure you all know how much time and work it takes you to convince the family and convince the radiologist to do for you the CTs and VQs cone. Normally, when we are diagnosing a DVT, physical examination, clinical decision rule, D-dimer, Dopplex, contrast, CT, and MRI are, like say, the list of the diagnosis. But if you look in reality, we are usually using the clinical decision rule, we are using the D-dimer, and we go to the Dopplers. And after that, the other three are basically the research are extremely rarely used. D-dimer is the Achilles heel for all of the doctors. You all have seen this. You all are facing daily this problem. The D-dimer is high, particularly now in this COVID area, everyone have a high D-dimer. So we have to see that the D-dimer have a good negative predictive value, but the positive predictive value is questionable. It's been investigated a lot with a variable success. There are new biological markers which the people are using, like say P-selectin, thrombin generation, and C-reactive protein. But currently, the only biomarker which every one of us is commonly using is D-dimer. So let's see the challenges of the D-dimer. It's not a standalone test, so don't look into it if someone sends you the paper alone. It should be incorporated into a diagnostic algorithm. The low clinical probability and negative D-dimer rule out the VTE, but if the clinical probability is high, you should never do the D-dimer and ignore it, whatever the result is. And this is the problem with most of our hospitalized patients, but in outpatient setting, the low clinical negative dimer is a value. The problem is the D-dimer is increased in a lot of conditions, in bleeding, in hemorrhages, in dissections, in distress syndromes, in arterial thrombosis, fibrinolytic therapy, AFib, COVID, malignancy, pregnancy, preeclampsia, sickle cells, hospitalization, old age, disability. Can you trust us? These are the challenges for us. Most of our patients are in this group. If I see a high D-dimer, will I believe it or not? Is a challenge. And again, it comes back to the clinical decision. It could give you the false negative as well. The thrombus, which is 14-year-olds, is false negative. If thrombus is very small and subsegmental, it will be negative. Strangely, the cough when thrombosis is small, it could be negative. Subsegmental PE, it again could be negative, but sometimes both of them needs treatment. If the patient is an anticoagulant, if it's maybe the D-dimers level are fastly reduced. So don't perform D-dimer on an anticoagulant patient. And there are studies on NOAC as well that the D-dimers are, like say, not very reliable, the negative as well. Again, what should be the threshold of D-dimer, which we should say? Up till few years ago, we all were using the fixed D-dimer of a 500 micro as a cutoff point, but now it has changed. We are looking into the age-adjusted D-dimer cutoff, and it's really age into 10 microgram per liter, which usually you say is the cutoff point. So if someone is 70-year-old into 10, the 750 will be the cutoff for him, not the 500. So mostly now the patients are moving to above 50 to the age-adjusted D-dimer cutoff to reduce the exposures to the CTs and NGOs. Reference range are the one of the worst which you could see. In every part of the world, the different laboratories use microgram, use milligram, use fibrinogen equivalent units, use the nanometers, use the FEU, use the DDU. When I get the result from somewhere from the D-dimer, I look at what the normal result from that lab is, because it's challenging for me. Even within the hospital, look to SKMC, we are using microgram and someone may be using milligram and someone may be using hemogram. So it's confusing and it's challenging for me. The imaging, of course, as I say, compression ultrasonography is important. Venography, CT, and MRI, we will quickly go through. Normally in UK, when we request someone to do the Doppler ultrasound, they do only the proximal leg ultrasound, unless I request them to do the whole leg ultrasound. So I don't know what the practices in your area are, but normally the proximal leg ultrasounds are 90 to 98%. The whole leg is again 97%. But most of them, if it's one is negative, sometimes you need to do the serial compression. So make sure when you request an ultrasound, please request your radiologist to do the whole leg ultrasound rather than only the proximal leg. They don't support it, so the people think there is no distal or cuff DVT. It's operated dependent, it's less accurate for chronic DVT. Pelvic DVT are negative, proximal DVT may be negative, obesity and severe edema interferes with it, and casted immobilization devices, you can't do it. So it's good, but there are problems with it. Venography is said to be the gold standard. There are many disadvantages, we don't do it. CT, again, it's a high dose contrast examination, so we don't like to do it in the routine. MRI, occasionally in pregnancy, we do it for the pelvic, but sometimes if we unable to visualize even the pelvic pain in pregnant women with it, so it's difficult. MRI, no one do it. So it's just for the completion. For you, for the DVT, is Doppler, where you have to make it serial Doppler, proximal leg Doppler, isolated lower limb DVT, and whole, and D-dimer, which we don't know what to take it and how to take it. Similarly, in the pulmonary embolism, it's the physical examination, decision rule, D-dimer, CT angiography, ventilation, perfusion, contrast, and magnetic resonance. So the things are the same almost. Here, it's not only the Welch scores. We do the PE rule-out score, we do the Welch score, we use the revised Geneva score, we use the adjustment D-dimer threshold, but we use another one very important, which is called Ayer's algorithm. It's just 6-7 years now that the people are more going toward the Ayer algorithm and age-adjusted D-dimer than only the fixed D-dimers. And the Ayer algorithm is that you see the patient, are there clinical signs of DVT? Does the patient have hemoptysis? And is the PE most likely diagnosis? You only look for these three things in your ED or ER. If the D-dimers are less than 1,000, and if the Ayer's items are 0, the PE is excluded. And in most of the country, once these Ayer's are 0 and D-dimer are less than 1,000, you have to convince and request your radiologist to do the CTPE. They don't do it for you. If the Ayer's items and the D-dimers are more than 1,000, you have to do the CTPE. If the Ayer's item, which is the clinical sign of a DVT, hemoptysis, and PE, if one of them is there and the D-dimer is less than 500, then again PE is excluded. And if the D-dimer is more than 500 and any one of these Ayer is there, you have to order the PE. So this Ayer's diagnostic algorithm, it started from the Holland. They studied 4,000 to 5,000 patients. They come up with this. Most of the people are now doing it, and they're now even applying it in the pregnancy now. So the age-adjusted cutoff, and keep the Ayer's algorithm in your mind. Pre-test probability are the same, revised Geneva scores and Welch scores. And the problem for me is the same. Like say, if 4 to 10 will be the intermediate. Will I go for the intermediate or not? The intermediate is 20% of the probability. And if someone say to me, this patient have a 20% chance of a PE, I'm definitely going to do the test for it. And for the low probability of less than 5%, I will look into the patient and their cases. Imaging, what will you recommend? CTP and VQ. And whenever you are appearing in any exam in the world, this is one of the common questions which the examiner like most. What you prefer, CTPE or VQ scan? CT, the advantage of the CT is that it tell you about other problems in the lung as well, not only about the PE. So in one test, you can find out if it's not PE, what else it is. If you are going for the VQ, the radiation is less. For the VQ, you need to have a normal X-ray chest, and then the radiation's exposure is less, and it is more sensitive and it's more specific. For a chronic pulmonary hypertension, the people are going for the VQ. So if someone asks you, you will go for CTPA or a VQ in a general population, depending on the availability, if the X-ray chest is normal, and if there is risk of contrast, I will go for a VQ. If I'm not sure of my diagnosis, I will go for a CTPA. There's a new test which is coming up, which is VQ spectroscopy, SPECT. And that's it's a 3-image, it's a 3-dimension VQ scan. And it says it's much, much better than the simple VQ scan. It clearly tells you there is PE or no PE. And now they are starting the hybrid VQ SPECT and a low-dose CT to diagnose PE in a specialized group of patients. So it's a new test. If you have it in your hospitals, it's the best one to go for. If you don't have it, you don't have it. Thrombosis at the unusual sites are splenic vein thrombosis. The D-dimer have no value. So that's important thing. If you're looking for a portal vein, mesenteric vein, splenic vein, Budd-Chiari, false positive results are many because those are the patients which have other condition, and the negative, again, they say have some value, but no one have properly done it. So I will have to go for the Doppler, CT angio, MR angio, and all of them have their own challenges. Availability, time, contrast. The easiest one is the Doppler ultrasound. So for the portal, mesenteric, and Budd-Chiari, if you can go for the Doppler, that's the easy one. But if not, then you have to go to the CT angio and MR angio. And to arrange for them is a real challenge. Central venous thrombosis is again, it's The role of D-dimer is still uncertain in them. Sagittal, cortical, cavernous, sigmoid. These are the problems. Negative dimer has been reported to have a sensitivity of 93%. But again, the positive D-dimer, we do it. I personally do it. It gives me a hint whether the patient have a thrombus or not. But will you do it and will you exclude or include? The answer is no. The unenhanced CT is a challenge. 25 to 30% in the patient with the central venous cerebrovenous thrombosis, it will be normal. And if you are going to do the radiology, it's MR and MR angiography together, which will help. The plain MR have the flow artifact, which could limit the positivity. And MR angio, the problem is that between thrombosis and anatomical variant, the differentiation is difficult. So the challenges are still there. I'm highlighting the challenges. Unfortunately, I'm not giving you a solution. Let's quickly go through the cases that what are this? So this is an obese man who in the past has an DVT 8 years ago after surgery. He had a swelling of the leg and now he's coming back and his D-dimer is 1,500. And we are not sure, did he had now a new thrombus or not? This is the picture. So it could be anything. It could be post-thrombotic phlebitis, could be necrotizing fasciitis, could be cellulitis. It could be a new distal vein thrombosis. There's a very problem in these cases. Like say, the pretest probability is out of the window in them. Ultrasound D-dimer is not going to be of help for you. Can you diagnose the distal DVT with the ultrasound and will it tell you, is it a recurrent DVT or is it an old DVT? That's the issue, that's the challenge. So basically what you do is, and this occurs in 50% of the patient who have a DVT in the past. So post-thrombotic syndrome, we see a lot and we always have a problem, so we end up with the test. The negative D-dimer have some value, positive have no value. And normally we say if the new segment is occluded more than 10 centimeter, it should be considered as a new DVT. And if the compression is, if you can't compress more than 4 millimeter, it could be a new DVT. But again, it's very much operator dependent, very much experience dependent, and it's very difficult to say. The distal DVT is extremely difficult and challenging for ultrasonographer because again, a very high risk of false positive. 90% of them you don't treat, but unfortunately 10% progress to the PE. So again, a challenge to treat or not to treat and to diagnose or not to diagnose is a problem. Another patient who is the first pregnancy, she came with a hemoptysis and left leg edema. You are in the ER, and this is again one of the very common questions for those who are appearing in the exams, that what you will do in a pregnant lady. Venous thromboses are more, postpartum thromboses are more, first 6 weeks, postpartum increased risk, but the diagnosis and prevention are important because it's important for the fetal and maternal well-being. Here we are using a new type of a score which you can use, which is called the left score. It's the 3 clinical criteria: symptoms in the left leg, edema with the cuff circumference of more than 2 centimeter, and first trimester presentation. When these three, if none of these three are there, usually they say DVT is very less. But if 2 or more are there, the risk of a DVT is about 58%. So here we are not using the Welsh criteria, here we are using the left criteria. If you find a DVT in the leg, don't go for the imaging in the chest with the pregnant lady. In this patient, the left score was 2. We did the ultrasound. The ultrasound was negative. If the one you see a negative ultrasound in a patient, in the pregnant lady, please don't think it's negative. You have to repeat the ultrasound within 7 days. And if you cannot, or if you're still not sure whether it's a DVT or not, you have to detect the pelvic DVT, MRI, and all these things. MRV, you have to do it. So important thing, in a normal population, you can say it's for safely say, but in a pregnant lady who have the life criteria of more than 2 with the risk of 58%, go for serial of ultrasound rather than 1. And then she has a hemoptysis. So she is suggestive of a PE. So what you will do, again, we will do the years algorithm. I personally don't take the risk of doing years algorithm in the pregnant lady. I don't risk the baby and the mother. People are using it and they are very happy with it, but it's that guideline have not approved it yet. So I don't use it. The years algorithm, according to the Holland study, it avoided 65% of the patient going to the imaging. But personally, as a challenge, I don't use it. And again, they will say, you will use what? You will use VQ or you will use CTNGO. And remember, this is a very, very good, almost every exam, everyone asks. And not only the exam, every patient asks, because ultimately the patient will say to you, you are a doctor, you tell me what to do. So the CT scan, the problem with the CT scan is it's good because it tells you it is PE or not. The contrast theoretically is safe, but it is not 100% safe. And because the developing breast tissue in the female, pregnant female, there is a more risk of carcinomas. So basically, the risk of a breast cancer in the lifetime increased to 13% in those who has a CT NGO during the pregnancy. The common people have it, but it's 13% increased risk. And you have to mention it to the people. It's not common, but it is there. The VQ scan is good for the mother, but there is 1 in 1 million chance of a childhood leukemia because the fetus is exposed more to the radiation. So these are the things which you have as a doctor to tell them. The studies are, it is safe. Do we need to do it? Yes, we have to do it. If you have a normal X-ray chest, go for a VQ scan or VQ SPECT. If you have an abnormal X-ray chest, you have no option but to go for a CT NGO because the PE related mortality is much higher in a pregnant lady than a very, very rare chance of a breast cancer. But for the discussion, you have to go to both, and there is the same answer for both. You have always seen a patient of the CKD, and we see a lot of CKD here, diabetic, hypertensive, old age with the CKD. They are coming, and the problem with them is they come with a pleuritic chest pain and they come with a short of breath, and they are hypoxic. It could be fluid overload, it could be PE, it could be pneumonia. You're not very clear what it is. The clinical algorithm does not help you. The D-dimer is of no value. So what you can do, the only thing you have is, again, to go for the two things, VQ scan or CT. If the chest X-ray is okay, if you can do the VQ, if you can do the VQ SPECT, that's fine. If you can't go for it, then you have to take a risk, and then the risk is real, and the risk is the contrast-induced nephropathy. You have to convince radiologist, and you have to convince the family, and not only convince them. If I'm the patient and you are telling me, do this, I want to do the kidney angio, but you have the risk of kidney injury, I'll say to you, please explain it to me. What do you mean by kidney injury? So the problem with the contrast in related injury or the contrast induced nephropathy or injury, it has 6 or 7 definition. Creatinine more than 0.5, more than 25% in 2 to 7 days. Some say 3 days, some days 10 days. But generally, the contrast causes the problem in the kidney. But how much? They ask. It's from 10% to 35% contrast-related lung injury, depending on the score. And the people use Mehran score, and the people score other score. And it has a point, like say hypotension and heart failure, diabetes, age more than 75, creatinine more than 1.4, and anemia. All of these have a points. And then based on these points, you will tell them this much is the incidence of injury. Luckily, most of the contrast-related injuries are recoverable. A percentage of them go to the dialysis. And those who go to the dialysis are really, in reality, less, 0.04, 0.05. The common patient which come to our hospital with heart failure and with the chest and early CKD, if you look to their score is in the moderate range. The risk is 10 to 15%, and the risk for the dialysis will be around less than 1%. So I have to tell it to the patient, but it's extremely difficult to make your radiologist agree to do a CT angio for you. So if you are lucky, you have the VQ scan, go for the VQ scan. If you can't go for the VQ scan, then you have to either treat empirically. And the problem with the empirical is the treatment. I'm not discussing the management today. But which drug you will use in the CKD, whether you will use warfarin, whether you will use heparin, that's a completely new chapter. So it's a challenge. If you are in SKMC, don't worry, we will do everything for you. But if you are outside us, then it's the problem. Another problem for me, which I feel as a pulmonologist, as an acute physician, as a medicine, subsegmental PE with the new VQ scans and with the new CT angio, subsegmental PE is very easily reported. The radiologist, it's one line for him. For me, it is a 2 days headache because I don't know what I can do with them. So the subsegmental PE, some people say do echo for them. Some people say if the D-dimer is negative, don't treat them. Some people say you have to treat them. So this is the problem which we don't know. And I will come to the last one, which is the cancer patient. There's 4 to 7-fold increase. D-dimers and wells in combination, even the only 9% is predictable. So you can't check the D-dimer and you can't check the pretest probability. So you have to go for the PE, VQ scan, age adjustment D-dimers, and then have to see. And above 80, age adjustment D-dimer is important. D-dimer of more than 1,000 is important, but again, it's the CT, PE, and ultrasound. And as I started, I will end. In the beginning, it was a mystery, and at the end, it's a mystery. Diagnostic algorithms are important, imaging are important, D-dimers are important, age-adjusted D-dimers are important, the new years algorithms are important, but what you will do, CTP is important, contrast-related injury is a reality, what the incidence is low, VQ scan is the method of choice in some patients if available, elderly or cancer and renal patient was the problem, will be the problem, and will always remain the problem. So we still face the same challenges as years before. Thank you. I had to hurry up because the topic was big and I took 10 minutes for my PowerPoint adjustment. So I'm really sorry for the hurried approach.
Thank you very much, Dr. Athar. I think, inshallah, we will go into more discussion in the Q&As later on, and maybe we'll have more targeted questions toward some of the aspects in your speak. I would like to introduce Dr. Amna Al-Mehari, consultant hematologist in Dubai Hospital. Dr. Amna will be discussing today the use of anticoagulation in COVID patients. More than welcome, Dr. Amna, and you can start your speech.
Well, thank you, everyone, and thank you, Dr. Abdullah, for the invitation to speak about anticoagulation in COVID-19. As you know, COVID-19 has been our talk for the last year and a half. It's the only topic people talk about these days. And I'll just share my slides. Just a second. Okay. So yeah, it's a big syndrome. It has many symptoms. It can present from a wide range of asymptomatic patients to patients who develop ARDS and die. My presentation will be about hypercoagulability in COVID-19 and the use of anticoagulation. So hypercoagulability, actually, we don't have a very clear explanation. So far, the clinical studies are still going on. Still, people are investigating the hypercoagulability in COVID-19. But we have some facts that came up from by observation, by some controlled trials, and post-mortem, or like through autopsy. Basically, we have the Virchow triad as all thrombosis. Most of the thrombosis, we know that thrombosis, we have the Virchow triad. First, we have endothelial injury, stasis, and hypercoagulability. So, and these all contribute to thrombosis. Now, in COVID-19, they found out that the virus itself, the SARS-CoV-2, does like a direct invasion into the endothelial cells, especially in the lung, and causes cell injury. And also through the post-mortem studies or the autopsies, they found out actually there was a paper which was published by the New England Journal of Medicine early last year. Actually, it was around March 2020, where when they did the autopsies on the bodies, they found that there is endotheliitis and microvascular inflammation. And they think that this all contributed to the ARDS, which happened with COVID-19. Also, with a clinical studies, they found out that patients who have COVID-19 have a high level of complement, and this complement probably can lead to complement-mediated endothelial injury. They measured the C5b9 complement, and they found out that the value is higher in patients with severe disease, and they think that it could be a cause of the endothelial injury. Also, these patients with severe COVID-19 are admitted to the ICUs. They have catheters, they go into the cytokine storm, which happens, and there's a lot of mediators there, such as interleukin-6 and other cytokines, which all contribute to the endothelial injury. The second is stasis. As we know, all COVID-19 patients who are admitted to the hospital are requiring oxygen, and most of the time are on high flow oxygen. They cannot move out of bed. So stasis happens in all hospitalized and critically ill patients. And last is the hypercoagulable state. Again, in a clinical study, they found that there was a number of changes in the prothrombotic factors in patients with severe disease. They found out that factor VIII is elevated, fibrinogen is elevated, and there's the prothrombotic microparticles, the circulating prothrombotic microparticles are also high. The neutrophil extracellular traps levels are also high, and hyperviscosity. They actually measured the hyperviscosity in the ICU patients, where they got, I think, 10 patients, and they had a special gadgets used to measure the viscosity of the blood, and it showed that the patient had high viscosity. Something to mention definitely in COVID-19 is the D-dimer, because actually it's the star of the show. Dimer had been under a lot of investigation, criticism, and the talk in COVID-19. We know that there's a high level of dimer, and it correlates with the severity. The higher the dimer, the more severe is the disease. But dimer is still not specific. It can happen in many common conditions, like high dimer can occur in other infections. It can happen in other pneumonias. Not necessarily it's an indication of severity in COVID-19. And what is D-dimer? It's a degradation product of the cross-linked fibrin, and this tells us that there is thrombin generation and fibrin dissolution. So the other abnormalities that happen with COVID-19, which is related to the coagulation, is coagulation abnormality. There is an entity called COVID-19 associated coagulopathy. It's like CIC, or like it's similar to DIC, but different. Why? Because it's different because you will see prolonged PT-PTT. The platelet count is usually normal, or sometimes increased in certain patients. Fibrinogen is increased and the dimer is increased. So it's common. What's common between them is the prolonged PT-PTT and the high dimer, but they're not similar to DIC, where the fibrinogen is high and the platelet count is high. And the difference is that in COVID-19 associated coagulopathy, you will get more thrombosis than bleeding, but in DIC you'll have more bleeding than thrombosis. And with further studies, they found out that the factor VIII activity is high, the von Willebrand antigen is greatly increased, which also again correlates with the endothelial injury. And there is a small decrease in antithrombin and free protein S, and a small increase in protein C, which all again contribute to thrombosis. What we see mostly, as I mentioned, in COVID is normal or high platelets. Sometimes we will have low platelets. They did a study in a large series of patients who are critically ill. They found that 7% of patients with COVID-19 had low platelets, or platelets below 50. And we've seen actually even here cases of ITP associated with COVID-19. Patients present with COVID-19 and the platelets are very low, and we have to treat them with steroids, high doses of steroids, to maintain a normal platelet count. Now, the clinical features. As I mentioned before, the risk of thrombosis is increased, and we know that. Early in the pandemic, it was more. Last year, we had more evidence, or most of the papers or the observational studies which were published showed us that there is a very high prevalence of VTE in COVID-19, especially in the intensive care unit. And it was reported as 25 to 43% in ICU patients, despite being on prophylactic dose of anticoagulation. But later studies this year in 2021 gave us a reported risk between 5 to 10% in ICU patients and less than 5% in hospitalized medical patients. Maybe because the number is higher and they found that the incidence is lower this year. And what was noticed also that there is increase in microvascular thrombosis, arterial thrombotic events. We've seen a lot of strokes this year. We've seen a lot of myocardial infarctions and acute limb ischemia. And it's there. It's less than the venous thrombosis, but we've seen. I would say that we've seen a couple of cases this year who presented with these manifestations. So what do you do? How to evaluate thrombosis in COVID-19? So we start with laboratory testing. So all patients with COVID-19 should have a baseline FBC with a manual platelet count if the platelets are low, PTP, TT, fibrinogen, and D-dimer. And we repeat the test depending on the clinical status. I mean, stable patients, asymptomatic, you don't need to repeat the test, especially the patients who are in the outpatient setting. Now, most of the recommendations are not to test the patient and don't test the coagulation if the patient is asymptomatic and he's at home. And the main purpose of doing these tests is mainly to obtain prognostic information. As in, like, if the dimer is high, we know that the prognosis is poor because it tells us that this disease is severe. And imaging, we would do, as Dr. Said mentioned before, if a suspected VTE, you do the appropriate imaging to the organ which is affected. So we come to the management. The main issue with management, there is a lot of clinical, there was a lot of observational studies and clinical trials which had been published this year regarding the management of thrombosis in COVID-19, or the management of the coagulopathy in COVID-19. First, the debate was to give prophylactic or therapeutic. Now, what happens that most of the patients who come to you with COVID-19 come in like the cases are very acute and the patients are very sick. And the problem is that we don't have lots of high quality evidence that tells us about the efficacy and safety of the approaches, either to give therapeutic anticoagulation or just prophylaxis. But what we know that if the patient is having a documented thrombosis, he should be on therapeutic anticoagulation. But the issue is if the patient comes with COVID-19 and a severe disease, how to proceed. There was many trials talking about ICU patients, non-ICU patients, and outpatients. And most of the hematologists and experts in thrombosis who are in the American Society of Hematology, the American Cardiology Association, the American College of Cardiology, and the European College of Cardiology. The problem is there is discrepancy between US and Europe. They have different thoughts, different approaches. And I'll just show you the few studies which have been published regarding this. And usually, and now when we talk about intervention or anticoagulation, at what phase? We know with COVID-19, it's a disease of phases. We know, for example, that antivirals work early in the disease. But other factors like tocilizumab works better if the patient works better when the patient is in the cytokine storm phase. So where do we place anticoagulation? At the beginning, at the end? Do we give anticoagulation? I will let you know now. And dimer. I don't know if, but we have been using this in the management of COVID-19. This came from the European Cardiology College of Society, European Cardiology Society of Cardiology. And we used D-dimer in this, where they justified the patients are at high risk of thromboembolism or low risk, depending on the severity of the disease. If the patient was having a severe disease, usually they're kept on therapeutic anticoagulation, and then they would investigate for thromboembolism. If it was negative, they will continue on high prophylaxis, but if it's positive, they will continue on therapeutic anticoagulation. And then the other presentation that they presented with low risk, they would check the dimer, and depending on the dimer level, they will choose the dose of enoxaparin. And we all use, at least here, we use this approach for treatment. But then there were many studies which talked about the use of therapeutic versus prophylaxis. One of them is this HISA COVID trial, which is therapeutic versus prophylactic anticoagulation in severe COVID-19. This measured 10 patients. They had 10 patients who were in the ICU. And the conclusion was that therapeutic enoxaparin improved gas exchange and decreased the need of mechanical ventilation. And after that, there was a big study which included thousands of patients, which actually contradicted this information, which was published in, I think, December 2020. But then later in January 2021, this large clinical trial, which was a worldwide trial, where they gave more than 1,000 patients who are moderately ill with COVID-19 therapeutic anticoagulation, and the endpoint was reached, which is that the patient did not require ventilation or other organ supportive intervention with the therapeutic anticoagulation. But then like a new paper was published just 3 days ago, May 16th, 2021. There was the ACTION trial by the American American College of Cardiology, where they found out that that therapeutic anticoagulation actually was not beneficial. On the contrary, the patient had more, they were at risk of bleeding rather than that they benefit from the anticoagulation. In this study, they had 615 patients. They followed up for 30 days. And they found out that therapeutic anticoagulation with rivaroxaban or enoxaparin for unstable patients did not improve clinical outcome, and the risk of bleeding was increased. So what we see from all the recommendations, or the latest recommendations from all the societies, actually is to give thromboprophylaxis with low molecular weight heparin. And the prophylaxis dose, Clexan 40 milligram OD. You can change into the oral, the NOACs to let's say rivaroxaban 10 milligram OD. And the only situation where you give higher doses is when you have patients who have a high BMI. You can give them 40 milligram BD. And there are also, you can give higher intensity to people who already had been on anticoagulation. You can just switch them to heparin for the greater ease of management. So what we conclude is that individuals who have not had VTE, they are not given thromboprophylaxis after discharge. If the patient had, for example, severe COVID and they were treated, upon discharge, we don't need to give them thromboprophylaxis. And only in situations where you had to discharge the patient early, that you don't have enough beds in the hospital and they were discharged home, you can continue anticoagulation at home. And another recommendation, which was stressed on in most of societies, that individuals who do not require hospital admission for COVID-19 are not treated with antithrombotic agents. And when we come to documented VTE, when the patient has thrombosis, then you have to give them full dose anticoagulation for at least 3 months. This was for the management of the hypercoagulability in COVID-19. I wanted to mention a little bit the COVID-19 vaccine-induced immune thrombocytopenia, or the VTT. I'll just go through it quickly, because again, it's a new syndrome that they don't have much of information about it, but what they know that there are some autoantibodies which are directed against the platelet factor 4, which is similar to heparin-induced thrombocytopenia, but the patient is not exposed to the heparin, and they're just exposed to the vaccine, usually the adenoviral vector vaccine, which is the AstraZeneca and the Janssen vaccine. And what happens that those patients develop autoantibodies, which triggers, which puts the patient in the risk of thrombosis and the risk of thrombocytopenia and bleeding. Of course, as I mentioned, they don't have they don't know exactly how this happens and still don't have a full explanation. But they are still trying to do more tests on it. But what we know about it, that it's extremely rare. We heard about it, and after doing epidemiological study, they saw that the risk appears to be very rare. And at the beginning, they mentioned that it was more in young women, but then maybe because these are the people who took the vaccine at that time, more information is yet to come regarding who's at risk of getting this VITT. And most individuals present with symptoms of thrombosis. Among the patients who had the disease, they came with cerebral venous thrombosis, they had pulmonary embolism, that it mainly presented with venous thrombosis. Some presented with symptoms of thrombocytopenia, which is bleeding and petechia. And what they recommend that is we test only if the patient presented with symptoms. Routine platelet count testing or D-dimer testing following vaccination is not advised. And as I mentioned, what we can confirm the diagnosis is by documenting the positive PR4 antibody test, the same test that we use for HITS, for heparin-induced thrombocytopenia. And you have to make sure that you rule out other causes of low platelets and thrombosis. And the main points of management is giving anticoagulation for everyone in the therapeutic dose. Try to avoid heparin because it's the same mechanism as HIT, and they think, theoretically, they think that it might worsen if you use heparin. And you can, as I mentioned, anticoagulation should be given to patients who had VTE and for patients who did not have thrombosis to prevent the thrombosis. And the second treatment is by giving IVIG at a dose of 1 gram per kg daily for 2 days. And this suggests that it can prevent the complication and block the function of the antiplatelet antibodies. But what we can see that they can develop thrombocytopenia after giving them IVIG, and try to avoid as much as possible transfusions. Don't transfuse platelets as this might worsen the condition. And if the patient is critically bleeding, give the patient fibrinogen-rich factors to prevent, or if the patient has low fibrinogen, support them with cryoprecipitate. So that's basically my presentation, and I will be happy to take questions at the end of the webinar. Thank you.
Thank you, Dr. Amna, for the nice talk. It has a lot of aspects. Still, I think studies are being conducted to look into the doses, anticoagulation, NOACs in the use in the COVID, and much more studies. Without any further ado, I would like to introduce Dr. Salman Abdulaziz. Dr. Salman, consultant in ICU, in ECMO and cardiovascular critical care. He's currently in King Saud Medical City. Nice to have you, Dr. Salman, with us back again in the UAE. And would like to, today, Dr. Salman will speak about the use of extended anticoagulation in pulmonary embolism. Welcome, Dr. Salman.
Thank you, Dr. Abdullah, for the introduction. Thank you for the scientific team for the invitation to join your scientific forum for today. My talk today is about extension of anticoagulation after VTE. I just specified about the pulmonary embolism because I mostly deal with it in the cardiac ICU and the ECMO cases. So I'd like to show you one case presentation and then to have a review literature about the indications of extension of the therapeutic anticoagulation and how to make this deal. In addition, what are the available options? This is a 65-year-old lady who had presented to the emergency department during my training in Canada. And the main issue is the sudden onset shortness of breath. She was having initially lethargic symptoms, fatigue feeling, in addition to reduced appetite with significant reduction in mobility after undergoing glaucoma surgery. Her past medical history was significant for atrial fibrillation on beta blocker, and she had a previous thyroid cancer and a benign right breast nodule in her history. She had no previous histories of chest pain, shortness of breath, no history of thromboembolic disease in the past, and no family history of thrombophilic disease. The initial chest X-ray at presentation was normal, and the EKG was showing ST sinus tachycardia and in addition to ST segment elevation in the anterior lead. So that's why the patient was planned to be transferred to my institute for urgent PCI. However, before the transfer, the patient had sustained cardiac arrest in the form of pulseless electrical activity, and immediate cardiopulmonary resuscitation was undertaken for 4 cycles of chest compression. Then she had defibrillation, which required defibrillation. A sustained ROSC had achieved after 12 minutes of CPR, and for which she had received systemic thrombolysis, intubated in that hospital, ventilated and transferred urgently for cath lab in my hospital by the Orange service, which is the medical helicopter. And the distance between each hospital is around 150 kilometers away. So on arrival, the patient was critically ill, and the patient was on maximum doses of 3 vasopressors, and the patient was on high FiO2 of 100%, in addition to respiratory rate of 20 and PEEP of 5. The vital signs at presentation, the pulse oximetry was 92%, the heart rate was 127 per minute, and with the vasopressor support, the patient was having a systolic blood pressure of 102, and the ABG was showing severe metabolic acidosis and lactic acidosis as well. Examination was unremarkable except for no urine output from the Foley's catheter, and the patient was having cold extremities. So in the cath lab, as you see here, the patient was having the right coronary arteries and the branches, which were totally normal, and the left main, in addition to LAD and LCH circulation, was totally normal. So the interventionist decided to proceed for plan B because that does not explain all the scenario, and he decided to go for pulmonary angiography, which showed total occlusion of both right and left pulmonary arteries with bilateral thrombi. So in the setting of failed systemic thrombolysis and ongoing life-threatening shock, there was bilateral pulmonary embolism on the angiography. She was transferred urgently for cardiac surgery in the operation room for surgical embolectomy. And I would like to show you the TE, which was done before proceeding for the cardiac surgery in the OR. So you can see this is the 4-chamber view, and it's showing a dilated right ventricle with hypercontractile apex, which we call McConnell sign. And you can see also reduced systolic function of the RV. And on the short axis, RV inflow outflow view, you can see that the RV is massively dilated with significant reduction of the RV function, in addition to suspicious clot in transit. Here's another image, which is the transgastric short axis view with RV inflow view. And you can see that the patient is having a hyperdynamic circulation. So the ejection fraction is around 70%, which indicates a massive PE. And another modality to diagnose pulmonary embolism, rather than what was mentioned by Dr. Syed Mohammed, is the great vessels view by transesophageal echocardiography. And here you can see this is the right pulmonary artery, and there is a clot, and there is also reduced Doppler flow to the right side of the pulmonary artery. This is the superior vena cava, and this one is the ascending aorta. So we confirm this patient is having a massive pulmonary embolism by transesophageal echo. So the patient underwent surgical embolectomy, and now you can see in the TE after surgical removal of the clots from the right and left pulmonary arteries, you can see a better contractility of the RV, and the RV size had significantly reduced. And you can see here in the short axis view, the RV inflow and outflow view, the RV size is less than before, and there is a better contractility of the RV free wall. Here we can estimate the RV systolic pressure, and it is very important for the follow-up of the patient. So after the cardiac surgery, the RV systolic pressure was around 50 millimeter, which is still high. And in the cardiac ICU, this means a lot for us. The patient had gradual weaning from the cardiopulmonary bypass with aid of inotropic and vasopressor support. At the conclusion of the procedure, the requirements of inotropes and vasopressors had decreased, and she was requiring a lower amount of doses for that reason. We received the patient in the cardiac ICU, and the TE probe was already there, and we were assessing the hemodynamics continuously for that reason. Just remember that post massive TE, the RV systolic, the RV support is the most important approach that you have to achieve for the patient to reduce the mortality from massive pulmonary embolism. So we optimize the oxygenation and ventilation. We aim for a higher saturation, and we avoid hypercapnia. In addition, we have to correct the acidosis because it's very bad. It has a very bad prognosis for the RV failure, and we have to remove the fluid that distinguishes the RV by dialysis because the patient is not making any urine, and we have to reduce the pulmonary artery afterload and enhance the RV contractility by using IV Merinon infusion. We continued with the IV heparinization to prevent any clot formation, and the atrial fibrillation was managed by IV amiodarone infusion. On day one, because the patient was requiring higher pressure dose, again, we have to look for hemodynamic assessment by using the TE at bedside, and you can see that there is some pericardial effusion on the right atrium, but not causing tamponade, and there is reduced RV systolic function, which might be the reason for the increasing the amount of inotropic support for the patient. You can see the in the short axis the hyperdynamic circulation of the LV and a D-shaped LV because of pressure-loaded right ventricle. So after 5 days of inotropic support and vasopressors, the patient started demonstrating a gradual hemodynamic improvement with signs of neurological awakening. So we came down with the sedation, and the patient has started to wake up. We had performed a tracheostomy to facilitate the weaning from mechanical ventilation, and physiotherapy was ongoing on day one from admission to the critical care. And after 1 month of hospital stay, she demonstrated a very good renal recovery, and no longer hemodialysis was required. And the patient had showed very good respiratory improvement, for which the tracheostomy was closed. And the cardiac surgery ward also, we had requested another transthoracic echo to assess the RV as well. And it showed a recovering RV, and I'm going to show it to you. The patient was discharged on oral amiodarone for the atrial flutter, metoprolol 50 milligram BID for rate control, and warfarin targeting INR of 2 to 3 for anticoagulation. And you can see here the four chambers view on the transthoracic echo that the RV size and shape is back to normal. And you can see also the TAPSE of, which is the excursion of the tricuspid valve annulus within the normal acceptable range. In the short axis, you can see the typical donut shape of the LV with very good contractility of the pap muscles, and the RV is lunar shape, which is the normal acceptable shape for the RV on the short axis view of transthoracic echo. The patient was discharged, and she came to the clinic after 2 months, and another transthoracic echo was performed, which showed complete recovery of the RV. And patient had extension of the anticoagulation with apixaban, 5 milligram BID, because her renal function had improved. There was a difficulty of achieving a therapeutic INR, and that was the reason for shifting from warfarin to apixaban. A follow-up CT scan was also done and showed complete resolution of the pulmonary arteries. However, the lower limb ultrasound was showing residual, non-residual DVT as well. Patient was doing very well. Her functional status is back to normal, and I'm in touch with her, time to time to ask about her condition, and she is doing very well at home. This is the transthoracic echo after 2 months from discharge, and you can see the RV shape is normal with normal systolic RV function, in addition to normal excursion of the tricuspid valve annulus, indicating normal RV systolic pressure. Here is the short axis of the RV and the LV, and you can see the RV shape is normal. The RV systolic function is normal, and the LV short axis view shape is normal with very good normal contractility. So going to the literature about anticoagulation and massive pulmonary embolism, and as you know that in the acute phase, you have to heparinize the patient with unfractionated form or low molecular weight heparin. But when you are dealing with massive PE, just proceed with the IV heparin to facilitate the next intervention, which is either CPA systemically or doing catheter intervention, or the patient to be taken for surgical embolectomy. Once the patient is more stable, you can choose the oral form of anticoagulation, which is either warfarin or the new generation of anticoagulants, either apixaban, edoxaban, or dabigatran or rivaroxaban. Once the patient is discharged and regular follow-up by a multidisciplinary team is advised for a better input to the patient. And what is needed to the patient during follow-up is to do regular assessment for evaluation of the medication compliance. You have to assess the treatment effectiveness as well, monitoring recurrence, deciding on extending the anticoagulation, screening for impact on the patient quality of life, and recommendation of appropriate rehabilitation program as we did to our patients. Regular follow-up echo is also recommended for the RV size and function, in addition to the pulmonary artery pressures, okay, to screen earlier for chronic thromboembolic pulmonary hypertension. That is very important to avoid future CTIF, which is having a bad prognosis. If it's happening, the mortality rate within a year is very high. And if it is documented, you have to refer the patient for medical or surgical intervention. The godfather of guidelines for anticoagulation of DVT and pulmonary embolism is the ACCP guidelines mainly. You can also go back to the European Society of Cardiology for Management of Acute Pulmonary Embolism guidelines. However, you are free to choose whatever suits you. However, for me is I choose the best from both. And as you know that, the during the assessment and diagnosis plus treatment of the acute stage of pulmonary embolism, we anticoagulate for 3 months. But what is after the 3 months is you have to assess the patient in the clinic for either predicting VTE recurrence and what is the chance of bleeding risk if you extend the anticoagulation in the case of possible VTE recurrence. And as you know that the patients with unprovoked TE or DVT, they have a higher chance of recurrence along the coming months compared to the provoked TE or DVT by trauma or surgery. And you can see that the idiopathic or unprovoked VTE is having a higher chance of recurrence after stopping the anticoagulant therapy compared to the thrombophilic status compared to the surgery or traumatic induced VTE. So the international guidelines say that in patients with the first VTE that is unprovoked with a proximal DVT of the leg or acute pulmonary embolism and who have a lower or moderate bleeding risk, they suggest, which is a soft statement, to extend the anticoagulation therapy over 3 months of anticoagulation. And interesting article about the duration of anticoagulation after VTE management by Professor Walter Agino from Italy. And he was stating clearly that the unprovoked VTE is having a higher chance of recurrence compared to the provoked VTE by weeks once you stop the anticoagulation. And as you know that the cancer is also having thrombophilic status, but the chance of unprovoked VTE is higher than the cancer-induced thrombosis. When you decide about when you decide about the anticoagulation extension, also you have to think about the risk of bleeding. So the benefits by preventing recurrence of PE compared to death by major bleeding from anticoagulation. So you have to assess the patient what is the risk of death from mortality or from VTE compared to major bleeding or life-threatening bleed in case of the patient is having high risk. Which modality is the best for extension the VTE treatment? Well, this is debatable, but the literature is growing more with the, according to the patient status. So the question is, number one, you have to answer, is the patient is having high recurrence rate of VTE? And the question number two is, what is the chance of major bleeding or life-threatening bleed that may complicate the extension of VTE treatment? The third question you have to answer is, the patient is having cancer or no cancer? So if you have a patient with cancer, you have to extend the treatment with low molecular weight heparin as long as the cancer is active. However, some cases are applicable with the DOAC if the risk of bleeding is minimal and it's not a GI or genitourinary cancer. Aspirin is not the best choice for preventing the recurrence of VTE and is having a lot of bleeding complications compared to the safety profile of apixaban or rivaroxaban. Warfarin probably yes, okay, but however, you have to tailor the treatment for the patient, either warfarin or DOAC according to the underlying pathology of thrombosis, the patient compliance, and what is the home situation, in addition to the socioeconomic status of the patient. So just a quick review for the Amplify extension, which is the study had evaluation for apixaban used in extension of VTE after 3 months of treatment of patients with pulmonary embolism and DVT. And as they did just comparison between the apixaban 2.5 milligram OD, apixaban 5 milligram OD compared to the placebo. So we can see that clearly that the recurrence of VTE between the apixaban 5 milligram, 2.5 milligram compared to the placebo is lower, than the placebo. And the major bleeding risk of apixaban 2.5 is lower than the placebo and apixaban 5 milligram. So the conclusion from this is a safe use of apixaban 2.5 milligram compared to 5 milligram OD or DID, sorry, for extending the anticoagulation for those patients with unprovoked VTE to prevent recurrence of thrombosis. Another landmark study of rivaroxaban lower dose versus standard dose compared to aspirin for long-term prevention of recurrent symptomatic VTE in patients with symptomatic DVT and pulmonary embolism. And what they found that using rivaroxaban 10 milligram OD or rivaroxaban 20 milligram OD compared to aspirin is safer, okay, to prevent recurrent VTE on the extended anticoagulation. And they found that the rivaroxaban 10 milligram is safer compared to the rivaroxaban and aspirin in the term of a lower chance of major bleeding or non-major bleeding incidents. You have a lot of modules to predict the recurrence of VTE. You can choose whatever you like, but there are two things that you have to keep in mind is the D-dimer after stopping the anticoagulation and the gender of the patient. So men, they have a higher chance of VTE recurrence, and a higher D-dimer is a bad prognostic sign of VTE recurrence as well. So a male with a high D-dimer is the worst combination that may happen after stopping the anticoagulation to assess the recurrence of VTE. So just remember that D-dimer is a key for assessing the patient probability for recurrent VTE. And also we can use ultrasound of the lower limb to check for the residual vein clot burden. And if you find it, that it can predict the chance of recurrence of VTE. So the D-dimer is a good utility for the assessing the patient of extending the anticoagulation. And that was proven by one study published in the Blood Journal in 2014 by Frandoni, who is one of the famous authors in thrombosis. So if you are, having a patient with who had finished the treatment with anticoagulation after 3 months, you have to send the patient for, that's the concept of the study. So femoral and popliteal ultrasound, and you have to see a residual, if you see the residual volume, residual venous thrombus, okay, you can decide about extending the anticoagulation for a maximum of 1 year. However, if you see very good recanalization, you can request for D-dimer. And once the D-dimer is positive, you can decide about extending the anticoagulation. And if the D-dimer is negative, you can fairly stop the anticoagulation. However, you have to repeat the D-dimer 4 times in 3 months. Once it is negative, the patient is unsafe. No need for extending the anticoagulation. But if it is positive, you have to resume the anticoagulation. But the summary of the study, or the concept of the study, which can be applicable in your assessment of those patients with unprovoked VTE, is once the patient is having weak risk factors, okay, and unprovoked VTE, whether a DVT or pulmonary embolism, after 3 months of anticoagulation, you have to assess the patient for risk factors. If the patient is male with unprovoked VTE, yes, okay, you have to decide about extending the anticoagulation, whether high dose or low dose of NOAC. And if there is no risk factors, you have to assess the patient by the criteria I showed you in the table. If you don't have any positive criteria of those, stop the anticoagulation. However, when you have any of these, okay, decide about extending the anticoagulation for another period, which is should be assessed later on by either apixaban 2.5 milligram BID or a small dose of rivaroxaban. The conclusion is extension of anticoagulation is warranted if no risk of bleeding, and you have to request D-dimer. And if you have high D-dimer and the patient is male, or there is a residual clot burden on the ultrasound assessment of DVT, you have to decide about extending the anticoagulation. And the last message is NOAC may be the best choice for therapeutic extension in selected cases. Thank you so much.
Thank you so much, Dr. Salman, for the very informative lecture. Now I think we will go through Q&As. I think it's almost done with the time, but we'll take 10 to 15 more minutes with questions, if that's okay with everyone. So I will go with Dr. Salman first. So what about the malignancy risks when we speak about the recurrence? So if there is malignancy and cancer in this patient, so will that give you a thought of extending the anticoagulation, or you will go through the risk assessment for malignancy if there is any?
So cancer-induced thrombosis, when you are deciding about extending the anticoagulation, you have to consider two things. Either you are dealing with active case of cancer, or a patient who is undergoing or who's having ongoing chemotherapy. In that case, you have to go ahead for extension of anticoagulation unless there is a high risk of bleeding. And this should be considered or discussed thoroughly with the patient and the family of the patient.
Okay, thank you, Dr. Salman. Dr. Athar, say, what is you discussed a lot about the different diagnostic aspects in pregnancy, but what do you think is the most relevant diagnostic tests to be considered in pregnant ladies? Because there is a risk on the baby, there is a risk on the mother, there is a lot of radiation issues in both the VQ and the CT scans. So which one will you consider more?
Sorry, I was mute. Like, say, my apologies. I had to rush because I was the first speaker and there was a lot of things to cover. I received from the chat box a lot of the information that it could have been better if I was slow. I wish I was. But I think Dr. Salman covered and Dr. Amna covered most of the things which were very, very important. One thing to clarify, I got a question from someone that I say treatment for CKD is only available in SKMC. I did not say it at all. My apologies. I said that the SPECT CT VQ scan hybrid is usually available in the hospital like SKMC or any other big hospitals, but not in the small hospitals and in the AHS, which is most of the time the cases. Coming back to your question regarding the pregnancy assay, it's a very, very important question. And most of the time when you are looking into, like say, the Royal College of Gynecologists, when you are looking into the Royal College of the Hematology guideline, when you're looking to the ACP guidelines, almost all of them say that the risk with the radiation is really very, very, very low. What the thing is, it all depends on, you have to explain it to the patients and family. For me, the X-ray chest is important. If the X-ray chest is normal, you can go for the VQ scan, because the risk of leukemia in a child till the age of 16 is 1 in million, which is a very rare thing. If the X-ray chest is abnormal and if I'm not sure of the diagnosis, then the first thing you do is do the X-ray chest. Next is do the bilateral Doppler of the leg. If you find the PE in the leg, if you find the DVT in the leg, you don't need to go ahead. So that prevents the contrast problem. If that is negative, which most of the time it is, then the CT angio, though there is a risk of radiation to the breast and radiation induced later on the carcinoma of the breast, but the life and death of the mother due to the PE and the baby is more important. So both VQ scan is safe, both like say can be done, both CT angio can be done, X-ray chest is safe, all the three together are safe. If you do all these three together, still the radiation collective dose is not equal to what will cause the harm. But for the safety, X-ray chest and start with the Doppler and pray that you get a result from by it.
Thank you very much, Dr. Athar. Question for Dr. Amna. Dr. Amna, you discussed about the duration of initiation of anticoagulation in COVID patients, as now COVID management is becoming into different phases, cytokine phase, the viral phase. So where exactly do you want to start the anticoagulation, at which point? And maybe like you start with prophylaxis dose, then you go into the higher doses. Can you elaborate on that, please?
So basically all COVID-19 who are admitted to the hospital, which usually ranges between the moderate to severe cases and even ICU cases, are recommended to use prophylactic dose of anticoagulation. It can be any low molecular weight heparin. It can be Clexane or any other low molecular weight heparins. And escalating it to maybe a higher prophylaxis, as we mentioned, and I know the clinical the data that we got is not very supportive, but my own personal feeling is what we observed with our patients. We usually go with a higher prophylactic dose, which is 40 milligram BD of Clexane, let's say, for patients who are, let's say, more sick. They are at the phase where you think that they will deteriorate. But as a fact, most of the clinical studies stated that if the patient entered the ICU and is mechanically ventilated, there is no benefit from therapeutic dose of anticoagulation. So we would continue on, let's say, high prophylaxis, intermediate dose, or prophylaxis anticoagulation. And as I mentioned in my presentation, that people at home are not initiated on anticoagulation or antithrombotic agents, which are the mild cases of COVID-19. Despite the level of dimer.
Okay, one more question, Dr. Amna, with regards to the prolongation or giving anticoagulation for COVID patients upon discharge without the diagnosis of VTE, as previously with patient having high dimer or a sudden rise in dimer. So the dimer was initially 0.5, then suddenly above 20, but the patient couldn't do the imaging. So will you be like?
Yes, I would extend anticoagulation, especially if the dimer goes to a very high level. If I wasn't able to do the diagnostic test, I would extend the anticoagulation for 3 months, especially with a very high dimer. But intermediate rise in dimer, again, I would personally, to tell the truth, I would continue on anticoagulation for some time, because really we don't have an answer. There is no clear data. I would say that every society agreed on. Some societies believe that we don't need anticoagulations. Most of them believe that we don't need. Some of them believe that we need. But we know as a fact that COVID-19 is prothrombotic, and we've seen complications up to 6 months. I have a patient who's currently admitted who had COVID in February, and he's admitted today with a pulmonary embolism. So again, and no one can give us a clear explanation, and no one can tell us exactly if we discharge the patients without anticoagulation, they'll be safe. But I would weigh the risks and benefits. I would see how risky are the patients. If they're at high risk of thrombosis, I would personally keep them on some sort of prophylaxis, especially if the dimer remains very high after discharge.
Thank you very much, Dr. Amna. Dr. Salman, a question with regards to anticoagulation. is there any role of antiplatelets like aspirin in the extension of anticoagulation? So instead of Clexane or apixaban or rivaroxaban, is there the role of aspirin there? Because there is a few studies showing that aspirin can be used in prophylaxis for prolonged prophylaxis. If you can elaborate on that, please.
Okay, so the question is very clear and the answer is very clear. If you open the first page of the SCCP guidelines in 2016, and they just put one short paragraph in the what's new in the guidelines, and they filled one page about the aspirin role and VTE extension for those category of patients. So aspirin showed a lower efficacy to prevent thrombosis of recurrence after stopping the anticoagulation. And also the risk of bleeding from aspirin is higher compared to the NOAC modality of anticoagulation. So if the patient is in favor of deciding his choice after a thorough discussion between the treating physician and the patient, and he wants to choose the aspirin, okay, and there is no risk of bleeding, okay, that should be documented in the patient chart and to go on for this kind of therapy. However, is not the best first choice of extension of anticoagulation.
Thank you, Dr. Salman. Question, Dr. Salman, with the initiation of NOACs recently for prevention or for extension, what is the role of giving a patient Clexane itself and like the indication to keep on Clexane instead of DOACs or NOACs for the extension of anticoagulation?
Well, there's no one to stop you from even the guidelines, but they clearly wrote that patients should understand that the risk of heparin-induced thrombocytopenia is very high with the extension of treatment by low microweight heparin, number one. And I don't think that the patient will accept injecting him on daily basis with therapeutic dose of enoxaparin BID, okay, which is very irritating to the patient. And number three is the cost of the treatment is very high compared to 1 month regimen of either kind of NOAC. So the guidelines say NOAC, yes. However, those patients with cancer-induced thrombosis on active chemotherapy or active malignancy, the treatment modality is low microweight heparin. There is more publications and more guidelines about saying NOAC, whether apixaban or rivaroxaban, are safe except for GI malignancy or genitourinary system malignancy, or those patients who are having intolerance of NOAC, just stay with the low microweight heparin.
Well, thank you, Dr. Salman. Dr. Amna, maybe a question about in your presentation, we discussed the point of HIT, where you develop HIT after initiating the anticoagulation. When can you know that this is a question? When can you know that this is the reduction in platelets is secondary to the HIT itself, or the secondary to the progression of COVID and pneumonia itself that can induce thrombocytopenia?
We have a special scoring system that we use, the 4H scoring system. And the other thing is that there is a special test where you check for the antibodies. You check for the anti-platelet antibodies. The test is actually available in DHA also. If we have patients who are if you're suspecting HIT, we can do that test and we can know if the patients are having or had developed antibodies against platelets from the heparin, and we can reach a diagnosis.
Thank you. Dr. Athar, I have a question with regards to the diagnosis of pulmonary embolism in critically sick patient where I have seen a patient at certain point, the patient is having a rise in dimer in COVID patients, and he's critically sick, requiring a lot of oxygen. Or let's say he's on high flow nasal cannula, requiring 60 liters. And you want to take the decision of diagnosing pulmonary embolism. Any role of echocardiography? Initially, maybe Dr. Athar and later on Dr. Salman can elaborate in the ICU also about the role of echocardiography in the diagnosis itself. And can you initiate, like the patient is becoming like hypotensive, can you initiate thrombolysis with echo?
I think Dr. Salman did a very great presentation on it, but for thrombolysis based on the echo, there are specific guidelines. It's not only the hypotension, but the right heart strain, the presence of a thrombus. The problem in the COVID is it could be the COVID myocarditis. These patients have atrial fibrillation. They're on the high flow oxygen, and the churning and the high flow oxygen, they won't be able to go for a CT, they won't be able to go for a VQ. The only thing you could do is just check the bilateral leg Doppler in case you find a clot there. If they reach to the critical stage, they will be on a therapeutic dose of enoxate. Most of them have the D-dimer in the 20 range. So the rest is, I think, echo is an option, but how definite it could be, and will you then thrombolyzed base the patient of a COVID with a high D-dimer, almost a DIC type of a picture, and reaching to the critical care, it's a very, very difficult decision. I think Dr. Salman is better fit for it.
All right, thank you. So the football in my court now. If you have suspecting massive pulmonary embolism and the patient in shock status, okay, the patient in shock status, there's no chance sometimes to do a CT angiography, all right? And there's no chance you mobilize the patient to anywhere. So you have to do everything at bedside, which is including either transthoracic echo with compression ultrasound of the lower limb. If you see any clots in the compression ultrasound and you see RV dilated with RV dysfunction, okay, and there is no contraindication for systemic thrombolysis, just go for it. So this is scenario number one. The scenario number two is if the patient is in shock and intubated, we can proceed for transesophageal echo safely, and we can look for the main pulmonary arteries, and we look for the clots in the main pulmonary artery, right and left branch, in addition to all the signs of pulmonary embolism, and we can decide about doing systemic thrombolysis at bedside if there is no contraindication. What if the scenario is so complicated, as Dr. Sayed mentioned, that the patient is very ill and there are a lot of considerations? Don't worry about it. If you have an ECMO team in your institute, okay, just activate the ECMO at the initial 10 to 30 minutes of the acute phase of shock, okay? So they will come to you, they will fix the VA ECMO, you can do the TE or the diagnostic workup, including the CT angio. If there's anything recommending massive pulmonary embolism, you have to call the cardiac surgeon to take the patient to surgical embolectomy. So I'm prepared for those worst scenarios. In the past, you know, there was no ECMO literature and there was no ECMO teams existing in many institutes. But now we are doing a more aggressive approach for those patients. We have in Saudi Arabia here in-hospital ECMO team, and we have a national ECMO team covering most parts of Saudi Arabia. So we mobilize either by ambulance or by a special aircraft, and we go to the patients and we salvage them. So ECMO had changed a lot of this, you know, discussions, and I think expert people or expert cardiac intensivists and TEE and point of care ultrasound to finish the workup. and you proceed with the next step of management.
Well, thank you, Dr. Salman. I think the more ICU get trained for transesophageal echo, the more benefits we will get. Nowadays, I think transesophageal echo is becoming a standard because the transthoracic where you'll have a lot of issues while the patient is on oxygen, and you'll have the lung views that are not very clear. I think we reached to a conclusion in the seminar. I would like to thank all the speakers today, Dr. Salman, Dr. Athar, Dr. Amna. I would like to thank ICOM for the managing the event, and I would like to thank Pfizer for sponsoring the event. Thank you very much, everyone, and wish to see you next in upcoming events. All my regards and best. Thank you very much. Thank you.
Thank you very much, Abdullah. Thank you very much, Salman.
Yeah, thank
Amna
you.
and all. Thank you, Reem.